Welcome to BW Healthcare World. Today is World Arthritis Day, and with me I have Dr. B.G. Dharmanand, who is a renowned specialist in rheumatology with a rich experience of over 35 years, who is currently working with Manipal Hospitals, Bangalore. He has an expertise in arthritis, multi-system autoimmune diseases, osteoporosis, and musculoskeletal medicine. He is the president of the Indian Rheumatology Association, and he has handled numerous complex medical cases and is known for attention to detail, accurate diagnosis, and treating patients with empathy. Let's speak to Dr. Dharmanand and understand more about arthritis today. Thank you so much for joining in today on the World Arthritis Day. As we were discussing earlier, that the theme is around in your hands and take action. But it can only be true when people become aware of what arthritis is and what is it that they need to know so that they can take action. They're more empowered to do so. So my first question to you, Doctor, is that how big of a problem, how big is the burden of arthritis in our country?
Thank you very much for this initiative. And arthritis is one of the most common cause for disability in adulthood. And the most common arthritis is osteoarthritis. So as you know, there is no single arthritis. There are at least 200 different types of arthritis. Osteoarthritis generally affects middle-aged and older age individuals. And that is one of the most common cause for disability in adult age. And apart from that, in a middle age, rheumatoid arthritis is the most common arthritis, which affects multiple joints, and it is an autoimmune disease. And it comes much more commonly in women. And arthritis also can affect young children as well. So the entity called juvenile arthritis or juvenile idiopathic arthritis, it is the most common type of arthritis in children. And it is much more common than some of the leukemias and thalassemia, which we are all familiar with. And it is a disease, if not treated, can lead to significant disability and deformities. And it can, when the woman of the family is affected, the entire family dynamics can change. And it is 1 to 2% of the population can be affected with some autoimmune arthritis. And almost 50% of the women at the age of 50 will have osteoarthritis. And at 60 years, it goes to 60%. It is roughly half of it in men. Men have a thicker cartilage and they develop osteoarthritis a little later.
And Dr. Dharmanand, what is the cause of arthritis? What leads to arthritis?
Yeah, as I told you, arthritis is not a single entity. And if you are going to talk about autoimmune type of arthritis, like rheumatoid arthritis, lupus, and arthritis which occur in children, they are due to autoimmune etiology. Autoimmune means body's immune system, for some reason, attacks our own joints. Apart from joints, it can affect other organs also. But in these diseases, joints are predominantly affected. And it causes inflammation in the joints. And the inflammation, if it continues in the joint without getting treated, it can lead to damage. Once the damage happens, it becomes permanent. This is one type of arthritis. Another type of arthritis is due to osteoarthritis, which it is due to, we can say, age-related wear and tear type of arthritis, where cartilage becomes thinner as we age, and body tries to compensate by modulating. At some point of time, this compensatory mechanism fails. The joint fails. So we can call osteoarthritis as joint failure. We are familiar with heart failure, kidney failure. Osteoarthritis is joint failure. There is one more type of arthritis called gout. It is due to uric acid. Uric acid is a metabolite of protein metabolism. Most of us have an ability to excrete or put out the uric acid which is produced through our urinary tract. But in some people, the ability to excrete all the uric acid out becomes little problematic, and they can accumulate uric acid in the blood. And accumulated uric acid beyond certain point won't dissolve in the blood, and it can go and get deposited in some of the cartilage tissues. And when there is a fluctuation, when there is a dehydration, stress, the cartilage, the uric acid crystals in the cartilage comes out into the joint, and joint tries to attack it and prevent, kind of get rid of the uric acid crystals. That process causes what is called as an acute gouty arthritis. It can be very painful. It occurs in predominantly men of middle age, younger and middle-aged men.
And Dr. Dharmanand, since you are talking of different kinds of arthritis, what could be the early symptoms that people should be looking out for, so that they are not just going to a doctor only when the things have progressed to a stage where it's tough to treat it?
Yeah, if they have a pain in the joint, either in the back or at joints, any joint, and if the pain is not due to an injury or trauma, then it could be a beginning of arthritis, right? Particularly if it persists. See, sometimes you do some extra activity and you get pain in the joints, and it generally settles down after a week or two of rest. It doesn't seem to settle down. If it seems to continue, and if it is associated with stiffness in the joints, if you're not able to make a fist easily, and if the stiffness lasts for 30 minutes, 40 minutes in the morning, and you start feeling like a stiff person in the morning, either in the joints or in the back or a buttock joints, all these joints can be affected in various types of arthritis. That is the time we should probably go to the doctor and ask whether it can be an arthritis.
And what are there any tests to diagnose this?
Yes, the diagnosis has to be suspected by the clinician. And once the diagnosis is suspected, if you do a test, it is much more useful. Because if you do arthritis test, because some of the tests are positive in 5% of the population, and many of them will never go on to develop arthritis. So we cannot use arthritis test as a screening test for the population, like what we do in diabetes. We can do blood sugar in everybody. If my blood sugar is more than 200, I am a diabetic, and I can be counseled and treated appropriately. But if my rheumatoid factor comes positive, I may be one of the 5% of the population where it can be normally positive as well. So only if the doctor suspects that I may have rheumatoid arthritis, if I have ankylosing spondylitis, whether I have a lupus, then they will order the appropriate test. Like the test like rheumatoid arthritis, anti-CCP will help us to diagnose rheumatoid arthritis. And there are X-rays we do, or MRIs we do to diagnose ankylosing spondylitis. X-rays are useful to make a diagnosis of osteoarthritis. Checking for uric acid in the blood will help us to make a diagnosis of gout. But test alone will not help us to diagnose. So you can't have a test and say that I have an arthritis. Patient should have a symptom plus test, then only the test carries a meaning. Otherwise, it's a useless kind of a paper in your hand.
And so you mentioned that some kind of arthritis are autoimmune among children.
Yes.
Yeah. How do we diagnose or know the symptoms what a child may be going through?
Yes. Children, we all know they are very active, playful, always jumping around. But if the child starts limping, dragging its limb, and cries while being carried, or refuse to sit in the floor and get up, and refuse to play, these are the situations. Okay, the kids may not complain that I have a pain in the joints. They may refuse to do certain activities which they would generally do, like climbing on the sofas, chairs, jumping around. If they stop doing it, and if they cry on being handled, then the mother or father should suspect that whether my kid may have a type of arthritis.
And Dr. Dharmanand, what are the kind of treatment options that are available to people once they have been diagnosed with arthritis? And if you can probably share that, different treatment options for different kinds of arthritis.
Yes. See, the first step is to make a diagnosis. Because of various reasons, the arthritis has a problem with its image. People, when they have a heart problem, they go to the cardiologist, they have a kidney problem, they don't think that it is untreatable, but the tag that arthritis, there is no treatment, has stuck for many reasons, because until 20, 30, 40 years, we didn't have very good medicines. We had only pain medicines and surgeries. In the last 2 decades, there has been an explosion of information and scientific knowledge and development of new medications. Now, if nobody with arthritis should ever go on to develop the deformities and difficulties and disabilities which we are all familiar with from the past. So the treatment options, a basic treatment is when somebody has a lot of pain, we use some pain medicines like non-steroidal anti-inflammatory drugs like ibuprofen, diclofenac. That is for a very short period to tide over the crisis. When I can't walk, I need to walk first. So I need to give some pain medicine. But pain medicine on a long-term basis can have its own connotations, and they have increased risk of renal, kidney, stomach ulcers, and also heart issues. So we have to use it very carefully. And people also use steroids. Steroids can be very effective in certain type of autoimmune diseases, particularly a group of disease called connective tissue diseases. Lupus is the most popular disease, and which can affect not only our joints, it can affect multiple organs, including brain and kidneys, where steroid can be life-saving. But for a routine arthritis, steroid is not used on a routine basis. It is used again for a very short period to control the disease. The mainstay of treatment is a group of disease called disease-modifying drugs. There's many drugs, at least 10, 15, 20 drugs are available in this category. We choose depending upon the type of arthritis. If it is rheumatoid arthritis, we choose a drug called methotrexate, hydroxychloroquine, sulfasalazine, etc. If it is ankylosing spondylitis, we use drugs like, there are different drugs called biological drugs. We use biological drugs, tofacitinib, that kind of drugs much more commonly in ankylosing spondylitis. So these are slow-acting anti-rheumatic drugs. It takes some time to work. It takes 1 month, 1.5 months to work. But until then, you need a painkiller. Then after that, they start controlling the immune system at a much more root cause level. Though we don't eliminate the original cause, but it can act there and control the inflammation, and the joint become better. So the patients can regain their function. They can regain their role in their society, their workplaces, and even the family, the mother and the father, they can perform their functions well, and children can go to the school. So the mainstay of the medication is called disease-modifying anti-rheumatic drugs. There are multiple drugs. And next option is a group of drugs called biologicals. Why they are called biologicals is because they are manufactured by a different process. It's called biological process. They're called bioproducts. So when we know which part of the immune system is wrong in a particular disease, they try to design a drug to address that defect or overactivity. So that kind of drugs are called biologicals. One example of that is anti-TNF. TNF is a molecule, tumor necrosis factor, which is implicated in ankylosing spondylitis, psoriatic arthritis, and rheumatoid arthritis. So you have drugs to reduce the levels or tackle that molecule. Their drugs can be very effective in treating rheumatoid arthritis. So this is regarding drug treatment. We should never forget lifestyle and also exercises, physiotherapy, all are very important component of arthritis treatment.
And are there cases where some kind of a surgery may be required?
Yes. Particularly, it is true in the case of osteoarthritis, because osteoarthritis is more due to degeneration of the cartilage, and there is no drug we can easily repair the cartilage damage. So some of the people, it can progress to joint failure. Once there is a joint failure, you cannot comfortably walk. You have to struggle to walk. You can't climb stairs. You can't travel easily. You can't get into the train, get into the plane, etc. That is the time joint replacement surgeries are used, and orthopedic surgeons are very, very well trained in doing the surgeries. And it has become a very common surgery now. Knee replacements and hip joint replacements have been very successful operations which are performed on a day-to-day basis in almost every hospital now.
And can arthritis treatment lead to a reversal so that person becomes absolutely normal, or some element of the challenge will remain?
Yes, this is a very, very important and pertinent question, because the outcome of any treatment depends upon how early the treatment is instituted. I will explain this with an example of heart disease. If somebody gets a heart attack, if there's a chest pain, if they are able to reach the hospital within, say, 2 hours, 3 hours, 4 hours, they go in the golden period, window period, that whatever is blocking the coronary blood vessel can be blasted and they can regain the blood. They can regain the function very fast, and they can be like functionally normal. They may have to take medicines to prevent this from happening, but the heart remains normal. Very similarly, we have a larger, little longer window period. First 3 months of any autoimmune rheumatic disease is a very crucial period. Inflammation starts in the joint. If an inflammation stays in the joint for long enough, it can lead to damage, and damage is permanent. So in other words, inflammation multiplied by time is equal to damage, and damage is permanent. This is the most important 2 sentences in rheumatology and autoimmune diseases. And if you are able to treat the patients early, the problem is the patient early because of various reasons. Because the rheumatologists are far and few, they are concentrated in few major cities. So the access to a rheumatologist can be a problem. Awareness amongst the public and the doctors are a problem. So getting a patient early is difficult, but earlier the better. Even if it is 6 months, is better than 6 years. So if we are able to control the disease with drugs very quickly, the joints can become totally normal, and even at the end of 10 years, 20 years, they can remain normal. So we have to control the disease quickly and keep it controlled on a long-term basis. Unfortunately, at this moment, there is no cure. In the sense, most patients cannot be without drugs and can permanently cure, but they can be with drugs and near normal. Like our blood pressure, you have a blood pressure tablet and take a blood pressure, and blood pressure remains normal and it can function normally. So at this moment, advancement has gone to this level, and curative treatment is not available for most of the diseases, including, except infections, no other disease is curable at this moment. So that makes lifestyle changes and preventive treatment, preventive strategies generally we take in life becomes very important.
Dr. Dharmanand, you mentioned that there are very few rheumatologists in the country. And so what do you think as a nation, since you're also representing the Indian Rheumatology Association, what do you think are the steps that we need to take as a nation so that we can get over this gap of the number of rheumatologists needed versus the available, so that we can make a progress in overcoming this disease burden?
Yes, this is going to be a slow process, because rheumatology as a specialty is relatively new specialty all over the world. Because until about 30-40 years ago, people did not know why arthritis comes. So most of the patients would get damaged. They would do all simple treatment, tender love and care, some external malish, and going to a spa, hot water fermentation. That's all they did. So because there was no treatment, the specialty did not develop for a long time. It was more towards rehabilitation in the past. With the advent of knowledge explosion in immunology, people understood what's happening in arthritis much better. Though by the time we diagnose, already the disease process which has started is already 5-10 years older. Before the patient gets the first manifestation, the process has started 5 years, 6 years ago, or 10 years ago. So that is the reason we are not able to totally cure it, because whatever started is started 10 years before. So I will not know whether what has started in my body until I develop a joint pain. So that is the reason the specialty took some time to develop. And when we started, there were only 2 institutions which had rheumatology training. Now we have at least 20-30 institutions have rheumatology training. And starting a training program in a medical college is a very arduous task. You need X number of beds, and there should be specialists, and specialists have to be employed by the hospital, and specialists should be paid reasonably well to start that. So that even the specialists who are available, who are in the private sector, and they're doing their job, they're serving the community. But to start a course in a hospital or medical college, you need much more dedicated effort from the government and the doctors as well. So we are trying as a Rheumatology Association, we are trying to impress upon the government to start rheumatology courses in various medical colleges, and it has been successfully started in many medical colleges. Now a lot of AIMS institutions have come across all over the country. Some of the AIMS, because they're much more independent and they're autonomous, they were able to start a course, because many times we went and spoke to the dean and we had a lecture, continuing medical education program. After that, they were ready to start the program. So we are trying our best, but it requires effort from the government, maybe demand from the patients.
Since you're talking
and public.
Yeah, absolutely. And since you're talking of the demand from the patients, most people do not know the difference between an orthopedics and rheumatologist, and which is where whenever somebody had a pain related to anything related to a joint, would typically go to a orthopedics. So for the benefit of our audience, can you differentiate and tell us the difference between an orthopedics and rheumatologist, and for what should a person come to a rheumatologist?
Yes. And with due respect to orthopedic surgeons, orthopedic surgery is a field, generally they deal with bone and joints, particularly with related to trauma and malignancy. That is their specialty in our country, which is at least 70-80 years old. And there are more training programs. Every medical college has got an orthopedic department, and orthopedics is a part of MBBS curriculum. So during MBBS itself, most of the doctors would go to orthopedic rotation. So orthopedics has become a basic specialty, and their specialty is trauma. If you fall down and have a fracture, if you dislocate your shoulders, and if you have some swelling in and around the joints, and if you have infection in the bones, if you have infection in the joints, they are the doctors, and they are surgeons, and they can operate. So any musculoskeletal problem which is related to trauma, injury, infections, or malignancy, they are the doctors. In contrast, rheumatologists are physicians. We are generally a general medicine specialist. We do our MBBS, we do MD general medicine, and then we do a super specialty or a subspecialty course similar to a neurology or a cardiology or a gastroenterologist. So we post MBBS, we are trained for 6 years to become a rheumatologist. So it is a general medical specialty, because the knowledge about immunology is important, and knowledge to deal with multiple drugs is important, because we are physicians, we are much more well versed in giving medications. Surgeons are much more equipped in fixing the structure by surgery. So we need much more wider knowledge of medications, and also many of the medications are immunomodulators. Some are immunosuppressives and steroids. They come with their own risk. So we have to very critically manage these drugs try to get the best effect of the drug without causing much side effect. This is an art. So that is one more reason it has to be physicians. Number two is most of the rheumatic diseases have multiple comorbidities, medical comorbidities like diabetes, hypertension, fatty liver, heart disease, and gastrointestinal disease. And basically, because we are physicians, as a physicians, we are trained to deal with most of the diseases. Like I will not do an angioplasty or an endoscopy, but we know about how to treat an ulcer, we know how to identify kidney disease. We should be an expert in managing blood pressure. And so it became a medical specialty, and you need a physician to treat a multi-system disease like rheumatic diseases, which affect multiple organs, not only a joint. It affects the kidney disease. As a doctor, I should also be able to look at kidneys without referring the patient to the kidney doctor. Only if for like taking a biopsy, I need a kidney doctor's help. If I suspect there is an ulcer, I need a gastroenterologist to do an endoscopy. But as a physicians, we know how to treat and how to identify and at least how to take care of these patients. So a rheumatologist, that's why a rheumatologist has to be a medical specialist rather than a surgical specialist.
And Dr. Dharmanand, what would be the common myths that you hear of from patients when they come to you related to arthritis? And what would you say are the myth busters that you would respond to them with?
One common myth I can think is arthritis occurs only in old people. So I'm only 30 years, I have an arthritis. That is what they come with a very big surprise in their faces, because they associate arthritis with older people. Because older people, we know that they are limping around. So osteoarthritis being the most common disease, everybody is familiar with arthritis, they associate it with old people. So, but arthritis can occur at any age, from newborn baby to 90 years or near to death. There are many types of arthritis which can come at each age. People who are older get a disease called polymyalgia rheumatica, which can be very crippling and which responds very well to a small dose of steroid. And if it is not identified, the older people can suffer a lot. So that is, and younger, as we discussed already, kids can get arthritis, middle-aged people get arthritis, young women can get disease like lupus, which has got an element of arthritis. So no age is a bar for arthritis. That is one myth I want to bust. Number two myth is there is no treatment for arthritis. There is treatment for arthritis. Every type of arthritis has its own treatment. We may not have curative treatment, but no disease has a curative treatment unless it is an infection. If you have typhoid, you can get cured. If you have tuberculosis, you can get cured. But if you have diabetes, you can be managed. So most arthritis now have efficient, effective treatment. If you have osteoarthritis, you have medical treatment, exercises. If they don't work, you have surgery. If you have rheumatoid arthritis, you have disease-modifying drugs. If you don't have, it doesn't work, you have biologicals. If children also can be managed with disease-modifying drugs and biologicals. Gout has its own treatment. So all arthritis have effective treatment. So the two things I can immediately think about. If you have anything, let me know. I can answer.
And Dr. Dharmanand, before I let you go, what would be your message to the world on the World Arthritis Day?
And ladies and gentlemen, if any of your kith and kin have an arthritis, either diagnosed or suspected, make sure that they see their family doctor. And most of the family doctors also are aware of the entity called arthritis. They are equipped to do the test. If you have access to a rheumatologist, look out for a rheumatologist. And a rheumatologist there in most of the district headquarters places, meet them. And some of the clues to suspect arthritis is pain in and around the joints, and the stiffness which lasts for more than half an hour, 1 hour in the morning. If the pain disturbs you in the night and prevents you from turning in the bed, it can be ankylosing spondylitis. Suspect that disease and go and ask the doctor whether it can be ankylosing spondylitis. If the child refuses to walk or play around, think whether the child has childhood arthritis and talk to the pediatrician whether it can be childhood arthritis. We have pediatric rheumatologists now. We have a good training program in a couple of centers for pediatric rheumatology. So, my message is know about your arthritis. A lot of information is available in the social media. Be aware of it, read about it. There is a treatment in modern medicine, and along with medications, also consider lifestyle modification. A good lifestyle is always a good antidote for you to develop chronic diseases. Thank you very much.
Dr. Dharmanand, thank you so much for taking our time to share your knowledge and experience with all of us on the World Arthritis Day. It means a lot to BW Healthcare World.
Thank you. My privilege.